right, well, good afternoon, everyone, and a warm welcome to all of you. We're so excited to be joined today by the Family Services team at New England Donor Services, who is here to share with us some of the creative communication strategies they've leveraged to facilitate donation conversations. My name is Deanna Fenton, Program Manager here at the Alliance, and as always, it's my pleasure to host today's program. Now, before I go ahead and turn the floor over to the New England team, I'd like to take this opportunity to share some keynotes and reminders regarding today's presentation. Now, for those of you joining us for the very first time today, we ask that you take note of the Q&A feature that's located in the Zoom navigation bar at the very bottom of your screen. All of your questions for our presenters should be submitted here. Once the presentation has concluded, we'll go ahead and transition to our Q&A discussion, where our presenters will address as many of your questions as time allows. Now, additionally, for anybody who may be participating in a group, we'd like to ask that you go ahead and complete this poll. The results will help us and our presenters gauge the level of participation and engagement in this particular webinar. So your assistance is greatly appreciated, and we thank you. Now, for anyone that's interested in our upcoming webinars, please note that registration is currently open for our next transplant-focused webinar. This will highlight the tale of two centers and their approach to expanding the donor pool through the use of DCD hearts. So you can join us for that presentation on February 23rd at 3 p.m. Eastern. Now, we're also excited to announce our next donation-focused webinar, which will focus on DCD in pediatrics. So be sure to tune in for that on March 9th at 2 p.m. Eastern. Now, as always, to stay up to date on all of our upcoming programs, we encourage you to visit our website at organdonationalliance.org. Now, following the conclusion of today's program, you are all eligible to claim continuing education credits. For this webinar, we are offering 1 CEPC credit and 1 nursing contact hour as a result of your participation. Additionally, a certificate of attendance is available for those of you who may be seeking CEs that are not being offered. Prior to receiving your credits and certificates, you will be asked to complete a brief online evaluation that will allow you an opportunity to provide us with your valuable feedback. If you happen to be listening in a group, please be sure to get that evaluation email from your group lead. As a friendly reminder, you'll have 30 calendar days to claim your evaluations and claim your credits. Now, without further ado, I'd like to go ahead and begin today's program by introducing our moderator, Karen Lord, Advanced Practice Donation Specialist at New England Donor Services. Karen, I cannot thank you enough for joining us today, and at this point, I'll go ahead and turn it over to you to introduce our speakers.
Thank you very much. Very excited to be here today and to introduce my friends and colleagues who first, I would like to introduce Stephen Everhart, who is the manager of our Family Services Coordinators team at New England Donor Services. He has a very large and long CV, but he's always very humble, and he really just wanted to introduce himself as the manager of the Family Services Coordinators. So thank you, Stephen, for joining and participating and presenting today. And his colleague and part of his team is Jennifer Grasso, who is a social worker. And again, she is a member of our extraordinary Family Services Coordinators team at New England Donor Services. So without further introductions, I would like to have Jennifer begin the presentation. Thank you, Jennifer.
Hey, Jennifer, it looks like you may still be muted.
Oh, it wasn't, okay. Am I there now?
We can hear you.
Okay, sorry about that. Hi, everyone. Thank you for joining us today. I don't know where everyone is coming from today, but we are here in snowy, cold New England with our 4th snowstorm in about 2 weeks. So thank you for taking some time out of your day to join us as we talk about some of the challenges that we are facing with COVID-19 and some of the creative communication strategies that we have implemented to help us with our donation conversations. So I'm just going to go quickly over our learning objectives. So we are going to review the impact of COVID on our donation conversations, and also look at how the dynamics of our donation conversations have changed with COVID-19. Provide some strategies to coordinate successful phone approaches with potential donor families. Identify approaches for effective donation conversations with donor families in DCDD cases. Summarize the process for navigating the DCDD cases when family isn't available or able to watch withdrawals. And talk a little bit about how COVID-19 has impacted the family support that our hospitals can provide. Okay, it is not letting me control the screen. Sorry about this. Let me go back. Okay. Before we go on to talk about a little bit about New England Donor Services, I did want to take a minute and have a poll just to get an idea of how long all of those of you who are attending have been working in the donation or transplant field. All right. Thank you. Thank you all for taking that poll. So it looks like the majority of us have been in the field about 1 to 5 years, with a few newer people under a year and some others 5 to 10 years, and then a good percentage also who have been in the field for about 10 years. So thank you for that. I just want to acknowledge that even though Stephen and I are the ones who are presenting right now, that there is a collective group experience here. And just because we're the presenters doesn't mean we have all the knowledge, and acknowledging all of the work that all of you are doing. So thank you for popping on my poll there for a minute. So Stephen and Karen and I work for New England Donor Services. We are the oldest OPO in the country, established in 1968. We cover 7 states, 175 acute care hospitals, 12 transplant centers, and 30 transplant programs. And our mission is to save and enhance lives through donation. So as we all have lived experience with COVID-19, we are very aware as how it has impacted both our professional and personal lives. We are working and going to school from home. Some of that is happening simultaneously, as it is in my house right now. And it has changed the way we go about doing a lot of our normal day-to-day activities, including things like even our grocery shopping, or spending time with friends and family, going out to dinner, going to community events, participating in various activities. So it is reminded us that of the things that we have taken for granted, also being able to be with family and loved ones during the hills and the valleys of life. So I'm going to spend some time now sharing how donation conversations in particular have been impacted by COVID-19. And I apologize, I cannot switch my slides. Thank you, whoever's doing that for me. So one of the first things that we have seen is the increase in need for phone donation approaches. Hospital visitation policies are ever changing and evolving, and in some instances, families are not allowed on site. Uh, Often meetings are occurring via phone or via Zoom with medical teams and families. Um, Family members may be worried about compromising their own health to come on site or being exposed if they did come on site to be with their loved one during this time. I know I've had some experiences in this role. Early on in COVID, I was responding on site to a hospital, and I was in line with everybody else getting our visitor screening. And there were probably a good 25 to 30 other people, primarily family members who were there to see their loved ones. And as I was standing in line, a new visitation policy went into effect. So all of these people are standing there expecting to go up to see their loved one. Multiple family members for a patient, and all of a sudden, standing in line, probably told earlier in the day that they could go and be with their loved one. They're now told that the visitation has changed and it is one person per day per patient. So these things are ever changing, and people's reactions and responses were not so pleasant during that moment. But it is kind of how things have been evolving. Even within the same hospital and hospital systems, there are many incongruencies with visitation. It can even change from unit to unit, even on the same floor. So one side of the unit may allow certain things while other sides don't. Another hospital that we work with, the social workers are the ones who are responsible and make exceptions for visitation. So it depends on the hospital and the evolving visitation policies and whether or not families can be there. Often if families are allowed, it is only at end of life or when they have made the decision to make their loved one comfortable or allow natural death. It is also often time and person limited. So they may be given 30 minutes and 2 people can come or something along those lines. So what we're seeing is families are coming in to see their loved one and making quick comfort measures only CMO decisions at bedside because they know that they are able to be there with their loved one at that time. This can really impact the timing of donation conversations and our inability to hold formal huddles or our collaborative donation planning. It can often be very quick phone calls with staff to gather bare minimum details before we have to approach a family. Our healthcare colleagues are exhausted. They've been working tirelessly on the front lines of this virus for almost a year. They're super busy, they're super overwhelmed, and often short-staffed. Some of them have lost colleagues to this pandemic, yet they're tirelessly showing up for every shift to do the work. But it can be challenging to connect with them for all the things that we would like to do. When family can't be on site with their loved ones, there can be a feeling of disbelief to the severity of their loved one's prognosis or brain death diagnosis. They may feel like their family member is not receiving the best care or that everything has been done for them because they have not been able to be on site, to see the care, to have the conversations, to witness all the work that has been done, all the care that has been done for their loved one. So that can definitely pose some challenges. Pre-COVID, we were often able to utilize things like conference rooms, family rooms, consultation rooms to meet with family members. Since COVID, many of these shared spaces where we may have had the opportunity to meet and gather with families have been closed or repurposed to provide sometimes staff additional spaces for them to take their breaks and things like that. So that has also posed quite a challenge being on site to try to find a place where we can stay 6 feet from family members and not be at the patient's bedside and be in a place where we can have confidential or, private, sensitive conversations. So this has definitely also posed a challenge for us in our donation conversations. Masks and shields, they provide barriers to keep us safe, but also then provide a barrier to some of our communication. When we're wearing a mask, it's sometimes hard to pick up on those little non-verbal nuances that people make with their face when you're only seeing someone's eyes. And if people have challenges verbally, due to their own health issues or things, sometimes masks can also garble or make it very difficult for us to hear clearly when we're trying to have a conversation and remain 6 feet away from people. I just actually had that experience yesterday on a case I was on where it was very challenging to speak with one of the family members, being 6 feet with a mask, based on their own medical condition. So that can be challenging. I spoke a little bit about the lack of consistency about hospital visitation policies, on the previous slide. But one of the things we are seeing is that a lot of hospitals are waiving quarantine and testing results to allow out-of-state family members to come into the hospital to be at their loved one's bedside, which, again, impacts us and our ability to have those conversations. Sometimes families are making very quick comfort measures only decisions in the emergency department. Hospitals are at capacity, and although family is not usually aware of and should not be aware of the reluctance to admit a patient when there are no surgical or medical interventions to offer and no chance of meaningful recovery, this has definitely led to an increase in our approaches in the emergency room or emergency department. Now, prior to coming to New England Donor Services, I worked in an emergency room for 10 years. And I can tell you that emergency medicine workers are some of the best people and busiest out there. And it can be challenging because they are not trained to manage organ donation or often work with donor families. So it can definitely pose some challenges in trying to huddle, make phone calls, get information in a level 1 trauma center where there are patients coming in the door consistently and constantly, and staff do not have the time to step aside to kind of hold those conversations with us. Okay. So now that we've talked about some of the challenges we're facing from the impact of COVID, I want to talk a little bit about our collaborative donation process, which we call the huddle, and why it's important for successful donation approaches, whether we are in person or on the phone. So the huddle, or the collaborative donation process. And you can see kind of what it is up there on the screen. So it is a collaborative discussion between the medical team and the family services coordinators or donation coordinators who are on site often to ensure effective communication between the healthcare team and the OPO. It is really important time for us to remind medical teams of no mention of donation, and so that we can provide some clear and consistent messaging to families, which optimizes our potential for a successful donation outcome. The goal is really to have a thoughtful, engaged conversation with families about donation, where we can explore values and dispel myths and misconceptions. And to do that, we need to have a very clear, consistent plan on messaging to the family. And we want to have as much information as possible to have that donation conversation with family members. So what are some of the things that we're talking about in a collaborative donation process or the huddle? Because it is a sharing conversation, so we may share with the team about patient's eligibility or registry status, but we also want to know what prognosis family was given when they came in, and what they know so far. And at what point did this become a grave prognosis? Who informed the family of the poor prognosis? Who's had the conversations, who may have a relationship with the family? We also want to gather information on the family's understanding of brain death or grave prognosis, the family's acceptance, and the timing. This exchange of information with the medical team allows us to have a family-centered conversation and be attentive to each family's experience of grief. Some other things that we like to find out is, what questions have the family been asking? This helps give us some information too on where they kind of are in their process and understanding of what is happening with their loved one. So if they're asking questions about potentially even, well, what do we do now? What happens next? Those are good questions for us to know that they have been asking. If family is asking, when are they going to wake up? When can I take them home? Again, good questions for us to know the family has been asking, because that really helps us determine where the family is at in their process. How family has been coping and who has been supporting them. Those are also very helpful things to know when working with a family. Where the discussion will occur. Is it happening in person? Is it happening at bedside? Is it happening in a family room? Is it happening on the phone? It's also really helpful for us to know who the decision maker or decision makers are, and any cultural or religious practices and primary language, all the things that help us lead an effective communication and donation discussion with families. So now that we've covered what the collaborative donation process looks like, I'm going to speak a little bit about the phone approach or the with families and how we can be successful with them. So one of the main tenets of what we do, and is kind of one of the basic things, is meeting the basic needs of families. So when we're on site, when we meet with a family initially, a basic needs conversation, although we don't call it that, might look like asking a family, do they need water? Do they need a snack? Have they eaten today? Do they need to take a break? Do they know where the restroom is? Is the room you're meeting in freezing cold and they need some warm blankets? Attending to some of those basic needs. Do they need tissues? Attending to some of those basic needs can really help a family feel a little bit more settled in and a little bit more comfortable. On the phone, this can be a little bit more challenging. And so when we're on the phone, there are some similar things that can be done. So we can ask the family if they need to take a break. Have they eaten today? Is someone with them providing support to them? Is there someone who can get their needs met if they need something? So that is always important. It is a good reminder when we're meeting with families in person, but also on the phone, that many times the person who is our family spokesperson, who's the person who kind of even if they are not the legal next of kin, but they may be the first person that we're having this conversation with. They're kind of the ones who take the lead, who kind of are looked up to by the other family members, the matriarch or patriarch potentially of the family. It is a good reminder that often those are the people who are putting aside their needs before anyone else. So they will not eat, not drink, do all that, but make sure every single other person that they're with is taken care of. So I think it is important, and especially important, to be aware of those family members who may stand out as the spokesperson or the leader in the family, to make sure that their needs are also being met, because they are often the ones that we don't think need it and most likely do. Another thing that we can do is personalize the conversations. And that is how we can establish relationships with family members, even when we don't ever see them face to face. And some ways to do that is to just know who you're talking to. So know who you're calling, know how they're related to the patient. Again, sometimes because we're not meeting with large groups, potentially like we have in the past, where multiple family members can be on site and be, meeting with multiple people, we may be meeting with someone who is actually not the legal next of kin, but who the family has kind of put forward as a spokesperson. So they may be our first point of contact with a family. So that is also important to know. Is this their legal next of kin? Is this just a family spokesperson? Knowing their name and knowing the patient's name can go a long way in establishing a relationship with a family. I actually just recently was on a case with a young adult with two parents, and it was an entire phone approach and conversation and follow-up. I've never met this family in person. And mom specifically thanked me for using her son's name in conversation. So sometimes it's those very little things that we can do to make sure families know, whether they see us in person or on the phone with us, that we are personalizing, that we are caring, that this is not just another case to us. And I also think it's important to review your case before you call. And that doesn't mean you need to know every single detail of every little thing that has happened throughout the patient's time in the hospital. But it is a nice thing, I think, for families, if it comes up, for you to have a little bit of an idea. Did they come in from an overdose? Was this a traumatic accident? Was this a suicide attempt? It is good to have some of that information. It may never come up, but I think it is helpful to just know a little bit about the situation when you are making the call. Gaining understanding and assessing families' understanding of their loved one's condition. Again, we're just acknowledging what they're going through, acknowledging the loss, acknowledging the big decision that they may have had to make, and asking and using open-ended questions really can help us gain understanding of what they know and where they are at in their thought process. Using open-ended questions help us gather more information. So noting the difference in these two questions that I'm gonna just ask. This is the impact of using open-ended questions. So one type of question, a closed-ended question, sounds something like this. Did you get a call from the social worker in the ED when your son came in? So that is a very closed-ended question. That is a question where, someone can say yes or no, and the conversation has stopped. Instead of a question like, how did you learn your son was at the hospital? That gives the family an opportunity to tell the story from their perspective, and so that we can learn from them. What do they know? How have things been for them? When we use those questions, we are really allowing the family to tell us the story. which is super, super important. It leads to, families really understanding and feeling like we are actually listening to them. One of the other things is the idea of active listening. Listening and hearing are two different things. So hearing is basically the idea of the sound waves entering our ear, and I'm not a medical professional, so I'm not going to go into the details of it, but it is the sound waves that we hear. Listening, on the other hand, is a process that ensures mutual understanding. And so when we're listening to someone, we're communicating respect to that other person. So we are listening and we are saying, I am here and I am listening to you. I'm not just hearing you, I am listening to you. And so that can be challenging on the phone. We can sometimes be distracted. The family members that we're speaking with can sometimes be distracted, which can lead, to challenges in active listening. But there are some cues that you can listen for and shifts in conversation that can happen, even via phone, that you can be attuned to. So, for example, someone has been very, very talkative and then just kind of gets quiet and the conversation kind of dulls a little bit. That can be a cue. Or sometimes, and this has happened to me, families are at home, there are loved ones there are children there are dogs there, as we all live our lives. Sometimes they are distracted. You can hear background noise, things like that. So anything like that, or shifts in the conversation where the family just kind of starts to go on something almost an avoidance type way. So when we are on the phone, we really have to do a lot more listening for those kind of cues, and really the active listening, because there is a lot, like I said, we cannot see in person that is going on. We cannot see body language and things like that. So we have to become attuned to picking up on cues from conversation. It's also really important to acknowledge the challenges of COVID-19. As I talked about before, we are all facing these challenges, as are the families that we work with. And not only are they impacting their time with their loved one in the hospital, but there's a lot of impact happening in their lives as well. And so it's important to acknowledge those challenges and concerns, to be attentive to families. And just as if we were meeting with families in person, families need time. So often in face-to-face conversations, we are meeting with families, and then kind of giving them time. So they may spend some time together without us present. They may want to make some phone calls. The same thing happens when people are on the phone. We are expecting people to make decisions, hear information, all of this stuff. It's a lot. We're asking families to do a lot, take in a lot of information and distribute a lot of information and make decisions. So there may be a need to allow family the time that we would allow them if we were meeting with them in person. So the time to speak with additional family members and manage whatever they need to manage for themselves. I think one of the things that we all worry about, even with in-person conversations, is how to manage strong emotions. And I think this is a challenge that we all face, whether it's in person or on the phone, is how do we handle if families have very, very strong reactions? And, I think using active listening, acknowledging that a family is upset, is angry, and letting them know that you're there to support them. Maybe it's not right now, Maybe they need to take a break, which is okay. And acknowledging that too. It is okay to take a break. It's okay to step out of this for a few minutes. And I think it's really important to remember that anger is something we have all felt and we can easily access, whereas grief is not always as easily accessible to people. Some people may have not experienced it or not understood what they have experienced as grief. And so it is easier to go to anger. It is something we know, we've all been there, done that, we get angry. It's much easier of an emotion to access and manage. So I find that important sometimes to keep in the back of my head. If a family is angry, I kind of try to flip the switch a little bit in my own head and see if I can see if this is coming more from an area of grief than an area of anger. So now that we've talked about approaching the family, I'm going to talk a little bit about how we can be successful with coordinating phone approaches with the medical team. Stephen's going to talk in a little bit about a little bit more detail about some of the types of phone approaches we have been doing. But I'm just going to talk a little bit about how we can be successful with some of these. So as we discussed, the huddle allows us to gather information and exchange information with the medical team. When planning a phone approach, there are some additional things to consider. One of them is the family able to come on site? What are kind of the rules for your unit, your floor? Education on the phone approach. Some medical staff are a little confused by it. They're used to us being there. They're used to us being at bedside. And so kind of just educating them on why this is the way we're doing things for this specific case. Again, identifying the key people for collaborative donation planning can be challenging via phone. Now we have to make multiple phone calls. We can't just kind of gather everyone at a good time in the hospital. And so really, it does take some work of making potentially multiple phone calls to the right people so that we can get the right information shared between us and the medical staff. Providing transitional language, timing, when is it going to be a good time to approach the family following their conversation, and a planned pause, which I will talk about in a minute. And then clear plans for follow-up. So I think one of the keys in working with families and medical teams during this is lots of clear plans for follow-up. So, I will call you back when I speak to the family, and if I don't get in touch with them, I will call you back at 1400 to discuss further how we're going to try to do this, or things like that. I think it's really important to be very clear. And that keeps plans from falling apart. So just a little bit about the planned pause. And so this is something that is implemented at the end of meetings, from end of life meetings, to help staff not raise donation. So this is when a family says we're deciding to make our loved one comfortable, or when they have been given the results of a brain death test. And this kind of gives everyone a pause so that organ donation is not mentioned. And what we ask is that staff say something along the lines of, why don't we take some time? I know it's very difficult for you and your family. When we can reconvene, we can discuss next steps. And so these are just some different planned pause scenarios. So if the patient's been declared brain dead, these circumstances can be very difficult and overwhelming. Please take some time. We will come back together shortly with a member of our support team to answer any questions and talk about next steps. If the family is having a goals of care meeting and they make the decision to make their loved one comfortable or allow natural death, I understand that you wish to withdraw support. Please excuse me while I, options, make arrangements, gather the team, notify my attending. In the meantime, another member of our support team will be in to talk with you about next steps. sometimes the family is at the point where they are ready to have that conversation. What are the next steps? They're asking, they're making plans already. And a good thing for the team to use is at the end of someone's life, all family meet with a member of our family support team who specializes in end of life to discuss your loved one's wishes along with your needs as a family. And please excuse me while I notify the end of life specialist. So those are just some wording and scenarios that can be effective. And so as we discussed, we want to make sure we are engaging families in thoughtful donation discussions with professionals who are trained to have those conversations. This allows us to engage in a values-based discussion in addressing any myths or misconceptions the family might have. So if the family does ask about donation, we do ask that it's not discussed any further and that they are notified that a colleague whose role it is to speak with families about this can answer any questions that you have. I'm now going to turn this presentation over to my colleague, Stephen, who is going to share with you some more information on the impacts of COVID-19 on our donation discussions.
Hey, Steve, just as an FYI, you're on mute.
All right. Yeah, for some reason, sorry about that. I could not get the screen to unmute. So I'm jumping all over the place now. Let me back up. Greetings all, Stephen Averhart, Family Services Manager with New England Donor Services. Thank you all for tuning in. Jen, thank you so much for that elaborate explanation on the collaborative donation process and how we go about phone approaches. And what I would like to discuss is how phone approaches have really been our saving grace within our DSA with the multiple hospitals that we interact with. As you can see, from 2019 to 2020, there was a huge jump. In 2019, we had 59 total phone approaches, which yielded a 66% authorization rate. And not knowing that COVID, the pandemic was coming down the pike, we had to jump into action. And I think that the preparation that we had done years prior, starting really in 2017, I think organizationally, we noticed that phone approaches was a viable option when having interactions with families. Certainly phone approaches aren't anything new. OPOs throughout the country have done them. We've reached out to next of kin who are out of the country, next of kin who are in another state and unable to come to the hospital, next of kin who have been incarcerated and unable to come to the hospital. And so we had some practice with it, but COVID really forced our hand and made us realize that this was a new reality for us. And so as you can see, from 2019 to 2020, 59 total approaches in 2019, up to 327 total phone approaches for the year of 2020, which yielded a 70% authorization rate. And interestingly enough, as you can see, the CDP, which Jen touched on a little bit, the collaborative donation process is higher with phone approaches than it was in 2019. And I'll talk about that in a bit. So what we found out is that it's all in the language. It's all in the introduction. I must tip my hat to our hospital relations coordinators who have been phenomenal providing real-time education to the care teams, making sure that the care team is aware of the information that we need to have a successful phone interaction with families, who's legal next of kin, who may be the decision maker, even though they're not legal next of kin, what are the contact informations, if the next of kin are coming into the hospital, if they have plans or flight plans of coming in to the state that the hospital is in, whether it's in Massachusetts, New Hampshire, Rhode Island, Connecticut, or Maine, what time they may be landing, so on and so forth, so that we can get our ducks in a row and figure out whether or not it is appropriate to either have a phone interaction with that family, or if they are allowed into the hospital, to wait and have a in-person interaction with those families. So when facilitating the phone discussions with hospital staff, there are certain different scenarios, certainly. The one that I'd like to focus on is when staff are on site and the family is allowed to come into the hospital. When possible, and we have wind that there's going to be an end of life or comfort measures only discussion with the family, we would like a donation coordinator, a hospital relations coordinator, or a family services coordinator to participate in those end of life meetings. The reason being is we find it easier to transition to that conversation of donation. Now, it is not always ideal, but if we have a family that is aptly grieving, they are accepting of the brain death diagnosis, or they're accepting of the poor prognosis, and the team will allow, we ask that our representatives be allowed to be in those meetings so that when the family asks what's next, we can easily transition that conversation to one of a donation conversation. In those instances in which NEDS staff is not on site, we try and provide different language tips to the hospital staff. One that I have incorporated here, in which the care team may be a little hesitant as we do more and more phone approaches. The word is out. I think the majority of the teams, the hospitals in our DSA are aware of our phone approach strategy, but there are some who've never interacted with it. And so we want to make sure that they are aware that we recognize that it may not be ideal based on their past experiences of having an interaction with the phone via, with the family via phone. This is a model that has proven to work for us. And we also want to make sure that they are aware of the fact that, you know, our goal is, was, and always will be to have a donation discussion with the family, whether there is an NEDS staff member on site or not. With the facilitation of phone discussions with hospital staffs where the NEDS staff is not on site, the language that we provide is that we work to the hospital care team is that we work closely with an organization that specializes in these sort of circumstances with the sort of loss that you are experiencing. Allow me to get in contact with them and they can spend some time with you to talk to you about next steps. Certainly, as you all know, who are in the OPO world, there are very inquisitive families out there who want to know what's next, who is this next team coming in. We try and have the care team indicate to the family that that's not their forte, it's not their expertise, but allow me to call Stephen or Jennifer or whomever who can answer these questions for you. In some instances where there are those families who are accepting and are aware that another member of the team is going to come in and have a conversation with them, if that patient is brain dead, has been declared, and is registered, in some instances we'll allow the care team to share that registry status with families. So the dilemma for us is what sort of phone approach we're going to be making, if it indeed is a phone approach. Is it going to be a cold call? Will it be an add FSC by phone, which is my personal favorite? Or will it be an in-person non-FSC approach? So what that means is that a family services coordinator is not on site, but a donation coordinator is on site, a clinical responder may be on site, or a hospital relations coordinator. When facilitating these discussions with hospital staff, and there is an NEDS staff member on site that is not a family services coordinator, when it comes to the cold call, there are several things that we take into consideration. One, sometimes when families are able to come in, they find out about the poor prognosis or that their loved one has been declared, they hightail it out of the hospital. They do not want to stick around to hear anything else. They're very emotionally overwhelmed and they just leave. In some instances, the care team doesn't even know they left the hospital. That's certainly an instance in which we'll make a cold call to a family. We also have to take into account which coordinator is on site. Is that donation coordinator or hospital relations coordinator, have they interacted with families before? What is their comfort level? Are they comfortable with interacting with families who are grieving? What was the last case that they were on? How did that unfold? Was it emotionally charged? Did it take a lot out of them? In those instances, we may also make a cold call to a family. And then there are also the instances in which next of kin who have been allowed on site refuse to leave the patient's room to go to another area of the hospital to have any further discussions. Due to COVID, which plays a factor, you know, for the most part, those environments are very closed. And so sometimes our coordinators who are on site, I personally would like to alleviate them having to go into such close quarters. And so at that point in time, I think that a cold call is in order. These run rather smoothly because we're able to have the contact information provided to us from the coordinator that is on site. We're able to identify who is legal next of kin, who is the decision maker, how are they grieving, what is their understanding. And at that point in time, once we have our ducks in a row, we then make that cold call to a family. And that interaction is fairly, simple. It's no different than what our operations in tissue do, right? I approached tissue for 3 years, and I still sometimes find myself amazed that I was able to call these families who I had never interacted with before, whose loved one is probably currently in the hospital morgue, and approach them about tissue donation. Organ donation is very similar in that regard. It's a conversation. And so though there is some hesitancy on making a cold call, it has been proven to be a model that is successful. As I mentioned earlier, my personal favorite is adding an FSC by phone. That is when we've made the conscious decision to make a phone approach to a particular family. And the family is on site, and we have a non-FSC on site. So again, a hospital relations coordinator, a clinical responder, an in-house coordinator. If they're seasoned enough and they are comfortable enough, what we ask them to do is to be our eyes and ears, right? They're right there on the unit. They're doing the huddling with the team. They're understanding exactly which direction the hospital wants to go in. They know who are the major players that are involved with this particular referral, and they know which family is on site. And what this allows us to do is a dual approach in a sense. So how it looks is this coordinator will, once appropriate, once the family has been informed that their loved one has been declared brain dead, or the family is leaning toward or made a decisive decision to allow their loved one to be removed from the ventilator, the coordinator on site will go in, introduce themselves to the family, offer condolences, explain what their role is, and then let that family know that they have a colleague who they're going to call who can talk to them about next steps. Also, another way that we found to be beneficial is the coordinator going into the room, doing everything that I just explained as far as introduction, condolences, with the family services coordinator on the phone. Once they offer those condolences and explain what their role is, they can say to the family, I have my colleague here, Stephen, on the line, who can talk to you about next steps. At that point in time, I'm placed on or the family services coordinator is placed on a speakerphone and goes into the approach. I like this a lot. I will be honest with you. It's hit or miss with some within New England Donor Services. Some coordinators are not that comfortable with going in on the phone. And if that is the case, then we'll just make a cold call. Those who are, it's been proven to be a model that's very successful, especially when those families begin to ask clinical questions. Though the family services coordinators are educated and have enough knowledge to answer those clinical questions, to have that donation coordinator or clinical responder in there in person, looking at the cues from the family, being able to read body language and answer those questions that from a clinical perspective, it really does allow the family services coordinator to just focus on the approach. There are some instances in which a phone approach is not ideal, right? A family is very emotionally charged. The hospital is at their wit end. This patient has been declared for several days, and the hospital has said to the family, by 7 o'clock tonight, we're going to be removing your loved one from the ventilator. That may not be an ideal situation to add an FSC by phone. There are also some instances in which some providers who haven't been provided with the data of how successful phone approaches are hesitant to allow a particular family to be approached by phone. We run into that from time to time, and if we do, we'll go ahead and make a cold call, or we will allow that non-FSC that's on site to make that approach, and then we'll provide some further education to that provider in a week or two. And sometimes there are some instances in which the dynamics are just off the chain, and it's just not appropriate to either take a cell phone into a family meeting, or we can always kind of identify by some of the characteristics of the family and how they're accepting or unaccepting of their loved one's demise. And we go ahead and make the decision to allow that non-FSC on site to have that first interaction with families, though we provide them with the transitional language needed. So I'm going to jump around a little bit and go into what we found in 2020. The data suggests that phone approaches are truly, a success for us and something that we should be keeping our eyes and minds open to in the future to implement them more and more. As you can see, the in-person data, 384 approaches leading to a 63% conversion rate. And with phone approaches, 70% conversion rate, with just a little under the same amount of approaches that were done in person, 327, as opposed to the in-person 384. For family services coordinators only, in-person versus phone, as you can see, in-person 317 approaches, yielding 67% conversion rate. Again, phone is winning, 327 interactions via phone, leading to a 70% conversion rate. Let's take out the brain dead registered. As you can see here in person, 230 approaches, yielding 56% conversion rate, whereas with phone approaches, 259 higher, 7 points higher, I think I can count, in which it's a 63% conversion rate. Interestingly, as I mentioned earlier, the collaborative donation process, which again, Jen spoke of, is timely referral, the no unplanned hospital mentions on behalf of the care team. If the patient is consistent with 9 out of 10 times that care team is following through, doing what they should be doing, which is declaring the patient, the collaborative donation process is higher with phone approaches than in person. Now, there are metrics that we need to be looking at because we have tried to put our finger on why this is the case, but there's no rhyme or reason. I hope to have that answer in the next 12 to 18 months. But this is consistent throughout our DSA, 72,000 square miles. CDP, the collaborative donation process, is higher when we are interacting with families via phone, whether they are on site at the hospital or if they're at home. I have some theories on it. I believe that, with the phone approach, we're eliminating the middleman, right? So let's take, for instance, a family is not at the hospital. They've received a call from the care team that their loved one has been declared brain dead. I think that most providers would find it rather abhorrent to, in the same breath, mention donation. So I think that donation is not being mentioned due to that. Let's take the instance of families being, they are on site, but the family services coordinator is not there in person to have a in-person approach for donation. I think that care teams are finding it a little bit uncomfortable to mention donation, knowing that there is no one on site that can back them up and come in and have an immediate conversation about donation. So those are just a few little quasi theories that I have. Certainly, we don't have an answer, but it's important. I think that this slide illustrates that there are some OPOs who are hesitant with the phone approach, the idea of the phone approach. This right here shows that it can be pulled off successfully, it's not going to increase the amount of unplanned hospital mentions by the care team. And it's also something that resonates with families because, and dare I say it, families don't know any better. They are preoccupied with the fact that, they're on the cusp of losing someone that they care about deeply. If we're having a genuine conversation that is embedded with empathy and compassion, it really does not matter whether we're in person or via phone. Donation always works itself out. It really, truly is a good thing. And I think that the message itself resonates with families. And with that, I will turn it over to the Q&A.
Thank you so much, Stephen, and thank you, Jennifer, for such a fantastic presentation, really honing in on the successes you've had with phone approaches and the CDP approach. So thank you so much for taking the time to kind of walk us through that and your experience. We really appreciate it. At this point, we'll go ahead and transition into our Q&A discussion. So for those of you who do have any questions for either presenter, please be sure to submit them in our Q&A box. Just as a reminder, that's going to be located at the bottom of your screen in the Zoom navigation bar. You can go ahead and just click on that and you'll be able to submit your questions there. Now, I do recognize that we're running a little close to the top of the hour, so we may not have time to get to everyone's question depending on how many questions we receive, but we will certainly do our best, and if need be, we'll follow up with you following the conclusion of today's webinar. But that being said, I'll go ahead and turn it over to Karen to facilitate our Q&A discussion. Thank you.
Thank you. Thank you, Jen and Stephen. That was a great presentation. And I really enjoyed that words that you use, like empathy and compassion and genuine. I think this says so much about the work with families and your care for them. The first question I have is asking if this PowerPoint presentation would be able to be shared. Stephen, is that possible or for your presentation to be shared?
Yes, absolutely. And I believe it's also being recorded, but if anyone would like the presentation, I certainly can email it to you. My email is very easy. It's Stephen _ my last name Averhart @neds.org. And I will be sure to email it to you right away.
Okay, thank you very much. One question I had was, has it been difficult for the hospital to buy into the phone approach?
To a certain extent, because it goes against everything that we know, right, when it comes to approaching. And, you know, I think that a lot of providers feel that, you know, especially in the beginning, how dare you have such a conversation via phone? But when presented with the data, it cannot be refuted. And so one of the things that, you know, people have often heard me say is that men lie, women lie, numbers don't. When provided with those numbers and the fact that it is a model that is working, that families have responded kindly, indicating that, you know, they received a lot of compassion and empathy, as you stated, Karen. I think hospitals, you know, slowly but surely are buying into it and recognizing that, you know, this model does also help to save lives. Certainly, nothing will take the place of an in-person interaction for a family that is grieving. But at the end of the day, we owe it to ourselves to think outside the box and implement new strategies to help bring donation and all its moral riches to those who need them, which are those awaiting life-saving gifts.
Thank you, Stephen. I don't have any more questions, and I know we were running short on time. So should we transition and say thank you so much to the Alliance for inviting us and hosting us today. We're very grateful.
Thank you, Karen. We certainly appreciate you, all three of you, for joining us and for sharing your experiences over at NEDS and kind of some of the successes, as we mentioned earlier. So thank you, Stephen, thank you, Jennifer, and certainly thank you, Karen, for all your efforts in helping us coordinate this presentation. And with that, we'll go ahead and conclude today's webinar. So thank you so much to our participants for joining us. We hope you found today's presentation equally as valuable, and we hope to see you soon in our next webinar. Take care, everyone.
Thank you.